Hi, this is Tim from ChiroUp, and I'm here for the short webinar that accompanies our clinical IQ test. This test was inspired by Malcolm Gladwell. In his book, David and Goliath, he talks about ways that we think differently to battle giants. And you and I, as practicing chiropractors, battle giants on a daily basis, whether that be business types of giants like insurance companies or a global pandemic, or clinical giants like challenging situations. Our drive, our knowledge, and our ability to problem solve is what defines our outcomes. And Gladwell talks about how the latter two are related to IQ, and there are two ways to measure IQ, through a standard test or a short 3-question test called the cognitive reflection test. So to test both, we had Dr. Steele take each, and I'm proud to announce he got all 3 questions right. Unfortunately, that was on the 30-question version, so he didn't see this question. This is question number 1 on the 3-question version. A bat and ball cost $1.10. The bat costs $1 more than the ball. So how much does the ball cost? Before you jump to an answer with your gut, I'll give you a second to think about that, and then later in the video, I'll give you that answer. This question asks us to use basic skills, in this case math, and our ChiroUp clinical IQ test asks us to use some basic skills that are problem solving and outcome boosting skills. Could someone with a low clinical IQ have good outcomes? Probably so. Would someone with a high clinical IQ have better outcomes? Very likely. Is our test perfect? No, but we hope that you'll enjoy it. So let's get to the questions. Question 1 was a gimme, hopefully so. A 12-year-old soccer player complaining of insidious unilateral knee pain is most likely suffering from which of the following conditions? Rather than read the answers, let's look at a graphic. We could have something affecting the tendon, the patellar tendon, the tibial tuberosity, the meniscus, or the medial collateral ligament. And since this was insidious in a young person, we're probably not dealing with a strain or a meniscus injury. And since we're dealing with the anterior mechanism then, either the tendon or the tibial tuberosity, it's going to be the tibial tuberosity in most cases. Because this tibial tuberosity is weaker than the surrounding tissue. In fact, in adolescents and youths, this tibial tuberosity and growth plate are 2 to 5 times weaker than what it will be in adulthood. So when something gives in a child, it's probably going to be that growth plate, so we have a traction apophysitis is the right answer. In this case, that's called Osgood-Schlatter's disease, where the tibial tuberosity starts to be irritated or eventually stretched away from the bone. Our clinical findings for this is that we're going to see that it's swollen. Sometimes it's even enlarged, and when we stretch that muscle, it hurts, and it hurts when we have that patient contract. Now, with regard to contraction, an easy way to do that is squatting. And one of the clinical pearls that I'd like to share is that squatting depends on where the pain is. If the pain is present during the ascent and descent, we're looking at something in the anterior knee or the patellofemoral region. If the pain is present at the bottom of that squat, we're looking at more of a meniscus, so hopefully something that you can use in clinical practice. How do we manage this? Well, we give that patient some selective rest. We try to decrease the inflammation, and we work out the tight tissues, especially the quads and the calves and the hamstrings. But most importantly, we need to correct the biomechanical faults, which takes us to our next question. Question number 2 is the following picture depicts what a chronic low back pain looks like when they squat on one leg. So which muscle group is weak in this case? Well, what we're seeing here is we're seeing that the pelvis is imbalanced, and we're seeing this knee dive into uncontrolled adduction. So those are things that align the frontal plane, and that would be the gluteus medius and the gluteus minimus. So we're going to strengthen the glutes in this patient. Let's take a quick review of those hip abductors. The principal hip abductor is right here, the gluteus medius. It comes off of the iliac crest and it inserts onto the greater trochanter. In this lateral example, you see off the iliac crest and onto the greater trochanter. And its defined action is to abduct the thigh, but in reality, it doesn't do that a whole lot. What it does is when I lift one leg off of the ground, it holds my pelvis level. If that spring is weak, so in this case, the right foot is on the ground, and if that right gluteus medius is competent, my pelvis stays level. But if that spring lets go and we have an incompetent gluteus medius, now it allows my pelvis to drop. But more significantly, when I squat on that one leg, it allows that knee to come into uncontrolled adduction, so we get a knock-kneed posture. Well, that doesn't sound so harmful until you look at the biomechanical chain. That knee coming into uncontrolled adduction puts stress on the medial collateral ligament. It's also pulling that patella relatively laterally, so now the lateral femoral condyle is rubbing it up against the lateral facet of the patella. That's a lateral tracking disorder, which turns into chondromalacia, which turns into patellofemoral degeneration at some point. We're also getting torque, that anytime that there's an anytime that there's an adduction of the knee and thigh, there has to be internal rotation of that thigh as well. So those two movements go together. And as that thigh rotates internally, now we get torque at the knee, and that torque is not appreciated by the anterior cruciate ligament or the other structures. It's also not appreciated downstream at the tibia, where we start to see shin splints or even stress fractures. And the combination of that adduction and internal rotation is pushing the arch of the foot down. So now we're going to see some stretching of the plantar fascia for irritation, stretching of the posterior tibial nerve, stress to the metatarsal joints, and there's a lot of discomfort that's going all down chain. But remember, this clinical example is a patient who has lower back pain. So why does that matter? Because when that thigh rotates inward, since the femur is L-shaped at the top, it throws the bottom of the pelvis backwards. It causes an anterior tilt of the top of the pelvis, which then forces the patient to go into hyperextension in order to stay upright. So our patient who has a lumbar spine problem, chronic lower back that's in hyperextension all day long, is not going to appreciate weakness. The good news is we can assess quickly. When the patient stands on one leg, do they have pelvic drop? When they squat down with two knees, do their knees come together? And most importantly, when we have them do a single squat, do we see this instability and unleveling of the pelvis? I'll give you a resource that you can watch this video lots of times so that you can assess all the nuances of it and better pick it up. But suffice it to say, it's pretty quick to identify patients who have hip abductor weakness, which is the majority of our patients with problems here on down. So what do we do for that patient? We need to give them some exercises. We'll give them something like a posterior lunge to strengthen that gluteus medius. We'll give them a series of clam exercises, either clams or clam with a band where they're spreading their knees. We can have them do a side bridge with abduction. We can have them do an advanced clam where they're holding their knees apart and allowing that leg to drop into internal rotation. The easy part about this is that it's pretty simple to prescribe those exercises. For me, I go into ChiroUp as the pro resource. I give the patient a condition report. So the patient with a lumbar facet problem or an intersegmental joint restriction who also has instability on their single leg squat, they're going to get a report that says, here's what's wrong and here's what you need to do. Most importantly, it's going to give them their exercises, pictures and descriptions of what has to happen, and a link that they can click on that then takes them to a video of that exercise. Love it because it saves me time. You can find that in our pro resources at the end at ChiroUp. If you're a subscriber, you know where to find it. If you're not a subscriber, I'll show you how to access that. Question number 3. Most athletes with a grade 1-2 sprain generally benefit most from which strategy? Now this is most, and this is typically. Is it the strategy of RICE, rest, ice, compression, and elevation? Or is it the newer thought processes of MEAT, movement, exercise, analgesia, and treatment? Well, in many cases, it's MEAT. Let's take ankle sprain. One of the most common conditions that we'd think to use RICE for would be an acute ankle sprain. And let's look at the data on ankle sprain. Well, when it comes to RICE, this study from Journal of Athletic Training said there's insufficient evidence to say that RICE actually works in this case. Does compression work? Well, there was lots of studies. This one from a couple of years ago, and there was just one that came out earlier this year that said compression garments really don't change the outcomes a lot in an acute ankle sprain. So what might help? Does rest help? Well, patients who have grade 3 sprains, yes, they're going to need immobilization and they're going to have to stay off of it. But if you have a grade 1 or grade 2 ankle sprain, we don't want that immobilized. And really that's true of a lot of sprains. When's the last time that we saw a cervical collar on a patient following whiplash? We don't use that, so sometimes it's not a good idea to immobilize other joints. We want to maintain that mobility and focus on regaining that range of motion as soon as possible, including the new tissue that's forming in the area. So what we want is movement. And this study said that if we can get that patient moving, those who do move have a 4 times greater likelihood of getting back to work at the 10-day mark than those who we put in immobilization. The last part of MEAT is T, treatment, and that means things that you and I do, manual therapy. That would include mobilization or even manipulation. In fact, this study said that joint mobilization is beneficial for improving balance after grade 1 and grade 2 sprains. There's a clinical prediction rule for who's going to benefit from manual therapy, mobilization, manipulation, and exercise. If you have 3 of the following 4 factors, there's a 95% success rate. So symptoms increase when you're standing, the pain is worse in the evening, the navicular drop is 5 millimeters, which basically means you have hyperpronation. The arch is giving away when you're walking or running. and you have tibiofibular joint hypomobility. There's a lack of motion. If you'd like to learn more about how to manipulate those joints, here's your pro resource, the Motion Palpation Institute. This is awesome for students. It's essential for students. It's essential for practicing providers. These are the experts in telling us how do we mobilize, manipulate, when it's appropriate, when it's not appropriate, and those skills. How would you like to be sitting next to Corey Campbell, letting him show you exactly how to mobilize it? Feel that yourself, practice it yourself, and then apply that to patients. Outcomes improve. If you're not currently a student of MPI, check them out, motionpalpation.org. You're going to like what they offer. Question number 4 is this patient who has neck pain and arm pain that runs down into their thumb has an increase in pain when they go through this movement. What are we going to do? Well, the first two might make you believe, let's think about TOS, but two things that suggest maybe not is number 1 is that the pain intensifies immediately. If we're creating ischemia from the first rib or the pec minor or the scalenes, yes, there may be a diminution in pulse, but that's usually going to take a little bit of time to produce a paresthesia or discomfort, not immediately. And could it be manipulation of the upper cervical region? Could be, may not help something that's happening at C6. The other thing about that TOS is most of the time that affects a C8 distribution, not a C6 distribution. 90% of TOS cases happen in a C8 distribution. So this one, we're looking for, yes, median nerve flossing. That there are a lot of tests that help us identify if a nerve is irritated. Think of straight leg raise in the lower extremity. That we wouldn't do an assessment of a lumbar radiculopathy without performing a straight leg raise. So why would we do an upper extremity assessment without performing the equivalent of that nerve tension test in the upper extremity? And there are tests for every type of nerve, or each of the nerves. The median nerve stretch test means we're going to stretch both ends. We'll stretch the brachial plexus up here. We'll stretch the hand and wrist with some extension at the wrist. And so that extension, just like Phelan's test, is going to put stretch on both portions of the nerve. And if that nerve is irritated, it's kind of like doing a Bragard's test in the lower extremity. The patient is going to have symptoms in that distribution. There's also a stretch test for the radial nerve, and that looks very similar. We're going to stretch the top end of that nerve, and we're going to stretch the bottom end of that nerve by having that patient move into the Butler tip position so that their hand and wrist are going into extension, and that's putting a stretch on each end. Now, there are stretch tests for lots of other nerves in the upper extremity. The difference between a stretch test and a treatment is that during a stretch test, we're trying to stretch both ends of the nerve. If there's a lack of mobility at the nerve, nerves are very dynamic. They're kind of like a bungee cord. So my median nerve is one length in this position. It's a very different length in this position where I'm stretching both ends. And over time, that irritation causes low-grade inflammation, which causes fluid to weep out and starts to spot weld that nerve. So now if my median nerve is trapped underneath the carpal tunnel, underneath the pronator teres, at the scalenes, in the cervical spine, and I stretch that nerve, it's going to create an ischemia, and nerves don't like tension ischemia, so they produce symptoms. So what we want to do is to break up those weak bonds, that weak glue that's formed in the area. Think of a hose that has a bungee cord in it that we've poured some weak Elmer's glue into, and now it's stuck. Well, to find out if it's symptomatic, we pull both ends, but to treat it, we're going to pull one end while creating slack on the other. So we're going to do some nerve flossing maneuvers, and in this case, the correct answer was median nerve flossing. And the way that that works is we're going to put tension on the top while we relax the bottom, and then we're going to put tension on the bottom while we relax the top. Think of taking that bungee cord and moving it back and forth in that hose to break up those adhesions. A great technique that if you'd like to learn more about, in ChiroUp, we have all of the nerve flosses that you can access and watch a video of that, both the practitioner-guided nerve flosses and the patient self-nerve flosses. But the experts on this would be people who teach that sort of thing, Gestalt education. So we're looking at the experts who can tell us about not only nerve flossing in this case, but Gestalt has some great classes on directional therapy, on dry needling, on DNS. These guys are awesome. So if you haven't listened to Brett Winchester and his crew, you'll want to check them out. Make sure that you take a look at that for the experts. Question number 5, your patient reports that they have some back and sciatic pain, and when they drive to work, it feels a lot worse. As soon as they stand up and take a couple of steps, it feels better. What exercises might likely help that patient? Well, does the hamstring tighten up when they're sitting? Yes, certainly so, but is it going to feel better when you take a tight hamstring and stand that patient right up? Probably not. TFL, not sure why that's in there, but these middle two you might have guessed, since they're similar, one of those would be the answer. And the answer is this patient is telling us basically that she doesn't like to go into flexion and sit for a long period of time, and her sciatic symptoms do like extension by standing up and walking. So that obvious answer is we're going to give her more of what she likes, a full press up. So in this case, we're talking about directional preference. So a directional preference means the patient is going to like either flexion or extension, and it's certainly much more complicated than that, but these would be the basics of that process. And the basis of directional therapy is that are we having symptoms that have gone from the periphery and have come back to the source? They've centralized. That's a really good sign. It means whatever you did to accomplish that centralization, keep doing. So when this patient stands in extension and they feel better, we're going to keep doing it. Versus pain that starts in the central and comes peripherally and then peripheralizes, that's not a good thing. Regardless of what treatment we're employing, anything that peripheralizes pain shouldn't happen. So when we adjust the patient's cervical spine and said, "Doc, that was a good one, it got down to my fingers," that should be the last good one, because that peripheralized the pain, and that's not something that we want to continue. We want things that centralize the pain. So anything that we do that moves that pain proximally, keep going. Anything that we do that changes that pain more peripherally, let's stop that process. So when it comes to this patient who has an extension bias low back pain, she likes to stand, we're going to try her in some low extension. So we give her an elbow prop up. And what happens to your peripheral symptoms? Yes, her back is probably going to be a little sore, but what's happening to the peripheral symptoms? Are they centralizing? That's good. Or are they peripheralizing? That's bad. If they didn't do anything, we'll give her a little bit higher version of this. So now we'll have her prop up into a full press up and say, now what's happening? Not in the spine, but the peripheral symptoms. And if they start to centralize, that's what we want to give her. If nothing's happening, we'll step it up one more notch and have her do repeated extensions, nice and slow, and then have her stand up and say, what happens in this case? And if she says, my back pain feels better, which that patient who drives to work and hurts when they sit and feels better when they stand, probably will tell you that felt better. So in that case, that patient is going to get an extension bias protocol where we send them home of more of the good thing, and we're going to keep them away from the flexion bias protocol. If we can classify our back pain patients into do they like manipulation, flexion, extension, traction, or stability exercise, and remember those aren't mutually exclusive. A lot of patients like more than one group, but usually not both flexion and extension. When we can classify those patients, our outcomes improve dramatically. And certainly the experts on this would be McKinsey Directional Therapy. If you've not taken one of their classes, I will assure you it's a game changer, and it's not for physical therapists only. There's a chiropractic division that's run by Jonathan Soltis, and it's fantastic. In Illinois, Southern Illinois in particular, we keep it simple. This is Floyd, his extension therapy every weekend. Question number 6. You've seen many of these patients. A drywall installer who's using a screw gun all day has pain for the past 3 months that's slowly escalating in his elbow, and especially during activity. What are we going to do for this patient? Do we want to suppress inflammation and get him to rest, or do we want to initiate inflammation? And in this case, we want to initiate inflammation. We used to think that chronic tendinopathies, whether it be a rotator cuff tendinopathy, a tennis elbow, a golfer's elbow, patellar tendinopathy, Achilles, we used to think it was a chronic inflammation of the area. And what we did was to suppress inflammation in the area. How'd that work? It didn't. So now what we do is we recognize that that's not a chronic inflammation, it's a failed inflammation. That yes, when you tweak your elbow once, the body's going to send in inflammatory products to heal the area. So there's an inflammatory reaction that maybe we do want to suppress a touch. But when we continue to aggravate that on a day after day basis, after about 3 days, the inflammatory products say, hey, if you're trying to chase us away, we're just going to go. You're continuing to irritate this, so we have no purpose here. And they take off. And rather than it being an inflammation, it turns into a tendinopathy or a tendinosis, where instead of it being red and puffy and swollen, we have this degenerated area where we have the collagen fibers that are disorganized, and there's a lack of blood supply to those fibers themselves. So now what do we do to treat those things is we try to stimulate a controlled inflammatory reaction. Rather than using ice and ultrasound and NSAIDs, we're using things like transverse friction massage and factor tools and eccentric exercise and manipulation, things that will stimulate some blood flow to the area. And how's that working? Very well. The experts on this, our pro tip is Factor. So they're using their Factor instruments to break up adhesions. They're using their dynamic taping in order to help stimulate some function, as well as the exercises and the protocols that make that work. So if you've not taken a Factor class, our pro tip here is check them out. The other thing that you and I can do is make sure that we're manipulating and mobilizing those joints. And it doesn't matter if we're manipulating the elbow. There's a lot of data to say that manipulation of the elbow works. There's data to say that manipulation of the wrist may work just as well. And certainly there's a ton of data to say that manipulation of the cervical spine has a direct impact on lateral elbow pain. And that's more and more by the day. So where you can reference more of this, our pro tip is to check out ChiroUp's condition reference library. Check out lateral epicondylopathy or medial or any of the other conditions. You'll see a green card with the most sensitive and specific orthopedic tests, the best practice management, and then the appropriate exercises, specifically the eccentric exercises, which have been shown to be very beneficial in these cases. You can pull up videos of any one of those tests. You can pull up videos of any one of those treatments and watch it at your convenience. And again, ChiroUp subscribers know how to access that. If you're not currently a subscriber, we'll show you how to access that in just a second. Question number 7. Which of the following conditions is not likely to be helped by spinal manipulation? Is it low back pain, lateral elbow pain, cervicogenic headache? And the answer to this one is obvious to you and I. Another gimme. They all have significant research saying that you and I have a major impact on those conditions. We know that because we see it every day in clinical practice. We see the research that supports that as well. But you know who doesn't know that? Is the public and primary care physicians. That they've not seen that data, or at least haven't paid attention to that data, and it's our responsibility to make sure that they know how to make that happen. So, in this case, we have a lot of resources that you can use and download. This is indications for referral. We give this to all the primary care physicians. It provides the names of the conditions where there's research to support what you and I treat, which is many. And then we have our clinical information on the back. We also have a little QR code that they can scan to see all the references. So it's not something that we're making a claim that's unsubstantiated. Our pro tip is to use that and other resources like this synopsis of evidence. This synopsis is about 15 pages long. It talks about all the studies that support the clinical efficacy, the safety, and the cost effectiveness of spinal manipulation for various conditions. The MDs in your areas need to be armed with this. But most importantly, the number one game changer here is the communication. Because the MDs can read the research about lower back pain from Annals of Medicine, from JAMA, that says, let's use spinal manipulation. But unfortunately, they have personal clinical experience that differs because we only see each other's failures. If I asked you to muscle relaxants work, you'd probably say no because you don't see a lot that work. Same with inversion tables, right? Well, those things can work. We just don't see the successes, and MDs don't see our clinical successes because only the failures follow up. So the way that we solve that is number one, communicating an initial report. For every patient who comes in, we're going to let the primary care physician know, here's what's going on, here's what I'm going to do, and here's how I'm going to treat the patient. But most importantly, we're going to send a release report of here's when your patient came in, this was my diagnosis, this is what I did, and this is how much better they are. So when the primary care physicians can see this process, that they see that number one, your treatment is effective, number two, that you do release patients, and number three, the patient was cared for in a safe way. It changes attitudes and it changes referral patterns. This by far is the number one practice builder that I've used in my practice, and the great news is we can automate this system for you. ChiroUp allows you to automate that process and deliver those reports instantly, and I'll show you how in just a second. Now, there was also a bonus question. The bonus question is, which of the following 4 conditions is most commonly present in the general population? Is it upper crossed, symptomatic lumbar degeneration, headaches, or rotator cuff problems? And I'll ask you to think about your last day of patients. What % of those patients would have each of these conditions? And I think that if you consider it for just a second, you'll say, yes, I understand why it was upper cross syndrome. Well, how do we know this? Because we have a little data that ChiroUp allows providers to prescribe condition reports that educate their patients about various conditions. So we took a look at our top 10 diagnoses for 2020. And what we found is that upper cross syndrome led the way by far. 43,840 reports have been prescribed so far this year with the diagnosis of upper cross syndrome. You can take a look at the others. You'd say, why isn't lower back pain there? Well, possibly because it's divided into lumbar segmental joint restriction and lumbar facet syndrome, which some people would classify as one, and then that would bring it up to a tie with upper cross. But upper cross leads the way by itself. So this is a functional diagnosis. And many of the things on this list, like lower cross, upper cross, scapular dyskinesis, are functional diagnoses that if we don't correct, that patient's problem persists. So our pro tip for this one, visit ChiroUp to prescribe those reports to your patient and get on board with that aspect. If you are a current subscriber, you know exactly where to go. If you're not currently a subscriber, we're going to give you 14-day access to ChiroUp. You'll have access to 100+ condition protocols. You'll be able to educate your patients with those reports, including video demonstrations that they can pull up on their phone. You'll be able to track your outcomes and get Google reviews to help you market your excellent outcomes. It'll also help you ace our next clinical IQ test. I hope that you've enjoyed this one. I hope that it's been something that's been beneficial to your practice, and I hope that you'll visit ChiroUp.com to get started today. Thanks for watching.